But the purpose was really to think through that when there is a crisis and there's a non-carceral, non-police response team that arrives at the scene and is responding to that crisis, where is that person taken if they need particular services? So oftentimes people are sent to the emergency room. And one of the things that our paper highlighted is that the emergency room can often act as a revolving door, similar to how the prison does, and not actually getting people the type of long-term and persistent kind of continuous care that they need. So the idea is integrated service facilities. It's not something that's brand new. This isn't something we kind of created or developed. Rather, it's kind of a framework or kind of a model to understand, service delivery in response to crisis. And the idea is that this is a facility that it kind of has, it's kind of like the dream of if, someone working in the field of substance use, mental health, homelessness, if people kind of came together and were given this, template of, what is the dream, facility that could exist, that could give people the things they need in the way that they need it, right? So again, thinking about how our health services are often so disconnected and they, operate in silos. They're not communicating together. You have a caseworker for your mental health. You have a caseworker for your substance use treatment. You have a doctor for this and a doctor for that. And so really trying to say, like, we want to just create a system that gets rid of that, because people who are in crises, people who are experiencing homelessness, people who have, the serious mental health issues, they're not in the place, to deal with that. And so an integrated service facility, again, is to say, what are some of the key things that we have recognized specifically around, mental health and substance use related crises? What are some of the key things that need to exist in a facility in order to facilitate the best type of, healing and, transformation in that person's life? These aren't fixes. At the end of the day, we're still kind of responding to crisis. We're not, these facilities can have a role in preventing, but they're not necessarily preventing them. They're not, providing the structural change that an individual needs to not be in that crisis to begin with. But, some of this response has been so clear. And so part of the polling was to kind of get a sense of how this has probably just been something that people also kind of just tend to agree on, regardless of political affiliation. And so, when we did the polling, there was about 58% of people, the likely voters, who have support of, integrated service facilities in their community. So just very general. But even people would go further to say, they'd be interested, 52% of, those who are likely voters support prioritizing resources for integrated service facilities over police and prisons, and including 36% of those of all the Republicans who responded. So there was kind of this idea of, we wanted to get a sense that there's public support for really addressing, again, like things that will address the root cause, at least, to some greater extent, knowing that, carceral responses, whether they're police or prisons, just don't respond to the immediate issue or really the underlying issue. A lot of times we have this traditional view of saying, people need to be punished or people need to be, treated a little bit more forcefully. And so there's kind of a desire to just want to cage these people. Honestly, that's kind of the response, is that we would rather just put these people away, people who have serious mental health issues. To take these responses is not to immediately vanquish, crises from happening, but it's to provide a more ethical and more effective response to them. Part of the report is it's supposed to be a basic model that, then we hope communities then kind of adopt in a much more specific manner, based on whether it's demographics, based on what's worked and what hasn't worked, based on what facilities might already exist in the city or in the community. The idea of these integrated service facilities is they shouldn't be like emergency rooms, right? Emergency rooms, again, are, they can be very just in and out kind of thing. And that's not what this is meant to be. And oftentimes when you think of, emergency crisis, 911, you think of like just these very point in time kind of events, right? So this thing happens, you deliver them, and then someone bounces, right? They leave, that's it. They drop them off and then they leave. We think of like a transportation service. And so I think what we're trying to do is to break that, cyclical nature by saying when someone's in crisis, what is the reason why they're in crisis? And I think one of the underlying factors is, a lack of a community, a lack of someone saying like, what was happening the day before that thing happened, whatever that crisis was. And I think it's to say like, we just need to reshape that whole, community environment. And so how does that end up, saving money in the long run as well? That you're going to prevent a crisis from happening in the future. I think another way in which we try to develop this idea of integrated service facilities acting as preventative, which again is, going to be cost effective in the long run, is that, these are open 24/7. And so the idea is that people walk in before they have a crisis, right? Again, there's this idea of, when someone is going through something, where do they go? And I think people have this idea that there's like these magical places that people who are unhoused or people who are, having an overdose, that they can just walk in. And sometimes there are, right? For instance, there are needle exchange programs or things like that where they can act like that. But, for a lot of people going through a crisis, there's nowhere where they feel safe or comfortable or anything to go. And we outline in the paper some of the costs associated with just emergency calls. It's a really, really great cost. And same thing with emergency department visits for substance use disorder or overdoses. These cost a lot, and people we pay that as citizens, as people paying taxes. People are constantly paying into that. And so I think this is where it's so clear and obvious that if you just address the root cause of these issues, if you provide a way for people to not just go and check into an emergency department for over a night and then leave, but to actually have a relationship built with this center, to say that you're not just taking care of my medical needs, you're taking care of my whole complete self, right? My all my social needs, that it's not just transaction and I don't get lost in the system. I think that is going to be a transformative type of service versus a one that's just very transaction based. One thing that's a conversation that's happening nationally and kind of globally is specifically related to substance use and opioid use. And I'm here in Los Angeles, and there's kind of now a wave of opioids, and specifically synthetic fentanyl that's being put inside the drug market, and specifically in heroin. And it's really reaching from the Mississippi River west. And so in that, we're trying to say, like, what are the responses we can have that is our life-saving responses that we know that works. And one of those are our supervised consumption facilities. And what those are facilities where individuals who are using drugs, and specifically injection drug use, can go and they bring their own drugs and they go and sit, and they're being supervised by a medical personnel. It could be a nurse, it could be a physician assistant, and they're just monitoring their heart rate, and they're providing needles and syringe exchange, things like that. And so these types of aspects right now, that's what these facilities function as. That's what they do. But I think to think of integrated service facilities as having that as a part of it is something that I think would be incredibly important. And it's because we know that when people use alone, when people use in isolation, they start to develop, even more dangerous habits. And so whether that's using needles that they find on the floor, whether that's overdosing and not having anyone around to administer Narcan, which reverses overdose. This is something that I would say is critical to an integrated service facility. As someone who spends a lot of time researching harm reduction and substance use and drug policy, this is just one that is incredibly important, because again, it provides the idea that if someone is a drug user and they have an opioid use disorder and they're struggling, or they have they're starting to use drugs chaotically and it's becoming unsafe, these types of facilities, they communicate something, right? This is the underlying part, that these aren't just buildings, right? These facilities communicate something. And what supervised consumption facilities communicate to people who use drugs, or people who are unhoused or live on the margins, and these things often intersect. What it communicates to them is, come as you are, and we will help you in as you are, and whatever you need, right? And so this is based off of years of understanding, how addiction works and what we can and can't do to just, get someone to just stop using. And so I think this is something that could shape integrated service facilities in a really cool way, because it also is, it challenges power in very important ways. And I think something that I've learned as I've studied, integrated service facilities or things like them is that these are not going to, while there is some, majority support in the polling we did, I think once we get like figures of how much they cost and things like that, I just don't think they're going to be, welcomed with open arms. I think there's going to be a lot of challenge to them. In Los Angeles, I'm seeing a lot of challenge to any sort of, progressive policies that push at, housing reform or giving unhoused housing options. So I think there's something that we need to say, that we need to be willing to push the boundaries of what, medical facilities tend to provide, the services they provide and what they communicate. And so I think this is something that, is hopefully something that's a part of all integrated service facilities, because oftentimes, drug use is involved in a whole host of things, right? It's just thinking about it and how it intersects with housing, with HIV and, infectious disease and a whole host of other things. And so I think that would be something that could kind of bring a radical kind of sense of, here are these facilities, these are centered around you and your experience and what you need, not what, those who are not going through a crisis need or want. We want to build power with the community, right? And when I say we, I say health professionals, academics, politicians, because unfortunately we have hoarded the power of what these types of facilities should look like, the types of people they engage, and where they should be geographically. Who has the voice, whose power gets to determine whose health. And so I think one thing to keep in mind is that the communities and the people that are oftentimes most heavily impacted by whether it's overdose or substance use or criminalization of drug use or mental health issues is often Black and Brown and Indigenous communities. And so it's not just kind of looking up and doing research to say, oh, what are the cultural practices of these communities, and how can we maybe hire people of the that to come and run these places, and make sure we have Black and Brown physicians and nurses. While those things are important, I'm not trying to belittle them. I think those are important. It's just to take a step back and say, how did we even decide who is going to be in this facility to begin with? How many doctors? How many nurses? Are there doctors? I guess like it's hopefully meant to be not just a replication, a copy paste of things we've done before. Part of what we were envisioning is this should be very different, because we have failed so much at this, right? We have failed to provide services and the technologies, the health technologies that we have, we've failed to make them accessible to the people that need them the most. And so I think it's a time to kind of just say, like, enough of just, Rafik and other people like me. And I think we have something to contribute, but when it comes time to actually building these up and designing them, I think it has to be by the people who are most impacted. And I think we love to say this, and I think the way in which we often do this is, we'll do like community engagement. The researchers will kind of go out, we'll talk to the community members, and we'll get a list of things that should be on there. But I think it's to really say, like, that they're in charge and they have the authority to really decide how this works alongside, the professionals. And, so I think it's really just to flip the script on how these are developed and how we decide what they look like. This is kind of the fundamental way in which racism operates, in which white supremacy operates, is it creates a decision-making structure, and the decision-making structure is limited by a certain demographic and a certain, socioeconomic status, and that decision-making structure always maintains the inequities. It's kind of by design will do that. And so if, when you said, how do we make sure that we don't replicate, the ways in which we've done it before, I think the most fundamental thing we have to change is who is making these decisions, who is allocating the resources, who is, deciding how much money goes to what, because we have tried it. I think we've tried it over and over with people like me, people again who are not directly impacted by a lot of these issues, and it hasn't worked. So I think that's one fundamental way to address kind of the racial inequities that medical facilities often produce and recreate. It's to say, like, how do we really embed these facilities with non-carceral logics, what sometimes is called, which is to say we don't want to punish people, right? These facilities, I've heard stories of people with with drug substance use disorders where they're inside the hospital bed and they're oftentimes being searched, and when their things are found, then the cops are called in and they're standing there over them, and or sometimes they're chained to the bed. So all of these things, right? If you ask someone who has previously been incarcerated, do you think this is the way we should handle, this type of treatment or service? They would say, absolutely not. That made it so hard for me to, have care or treatment. So again, it's just revisiting who is at the decision, who is making these decisions, and how is power being built with them so that they continue to make these decisions, make the changes and the improvements to these types of facilities. Right now, we're kind of working with a couple of folks in Santa Barbara, and they're kind of trying to build this out. And a couple of things we're working on is they're essentially trying to build a kind of a model that's detailed enough to submit for like grant applications, for instance. So for people who want to try to pilot this. So I think this is one area that I'd want to invest more time in, is just to provide people with a tool. Like, you're interested in building a integrated service facility in your community. And I think the reason why this tool is necessary is because I imagine going to, and again, I think it's good and important to try to build the political power to get buy-in from, politicians and things like that. But I guess part of me wonders, how successful would it be to, again, say, like, if we want to do this the way we want it to be, I think you're going to have to kind of do it a little bit more independently. So I think getting grant funding for these, piloted versions of this, whether it's from foundations, I think that could be an option. And so that's one thing, is to try and provide some sort of template for people to have to say, here's what I could, if I'm interested in building this up, here's like one step I could take to, here are the things I would need to identify, the community stakeholders or whatever it was. So I think this is from the perspective of community organizers interested in, being involved in this type of work and building this up, as one of the, one of their demands is, more equitable alternatives to incarceration. And so I think providing them with the type of a template or a resource to say, like, all right, here's how I can, start to build this out. How much would this actually cost? That's one area I think I'm interested in. I think the other one is, I think this idea of kind of building power with the community. So how do health services people, as they're involved in this process, because one of the things I'm worried about is the ways in which, you always have to think about how these things can be co-opted. And one of the ways I envision this, integrated service facilities being co-opted is, you get people are hired and they're said to build this, and it can be just done completely separate from the community. And the people that are going to be hired to do this are, public health professors and academics and researchers. And I think unknowingly, they don't know, but they're, kind of building a model and building a service that now has left the people outside of it, has left the community outside of it. So I think one thing I'm interested in thinking about is, how are, the people who have the expertise in, implementation science and health services research, how are they doing the work of their research there, alongside the community really well, and making sure that these integrated service facilities, maybe there's like, some sort of a list of things that, people say, like, this is what they must have. Like, it must have this, this, and this. It cannot have this, this, and this. And so to kind of really stay true to that. So I guess I'd be interested in to really like spending more time with, kind of the community organizers, people most impacted by this, to kind of have a wish list of, if you could really build out this thing that had everything you wanted, what would that wish list be? The last thing that I maybe is not something I would do, but I think is needed, again, is some of the financial parts of this. So, how is it being resourced? And kind of combining that with the centers that already exist. So, what sort of ways in which, how are they, doing this in a unique way that I don't know, the evaluation sometimes it might look a little bit different with an integrated service facility. So I don't know, like, I guess I'm curious, like, what would evaluation of a center like this look like? Is it going to use the traditional type of evaluation methods, or is it kind of dealing with, such a unique population and the types of services? It's, again, we're not just trying to envision, this service, put it here, just take it and copy paste. Like, I don't think it's gonna work like that. I think it's gonna be transformed in that process. So I don't know what the evaluation metrics are. I don't know what evaluating these types of centers look like. So I think, trying to think of ways in which these are going to be evaluated is really important, because we do want to make sure that they're working, they're doing what they're intended to do. But I'm also sometimes hesitant of some of our traditional evaluation methods, and what things are they missing? What things are they, so again, it's a little bit more, I'm not sure. This is just an area that I'm interested in exploring more.